This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub Podcast. I'm Dr. Aris, Senior Attending in Neurosurgery.
And I'm Dr. Elara, Research Fellow. Today, we're looking at a fascinating new study from the journal Brain and Behavior, published in 2026, titled Efficacy Assessment of Supramarginal Resection versus Gross Total Resection in Glioblastoma, a systematic literature review and meta-analysis.
This is a timely topic, Elara. For years, our North Star in glioblastoma surgery has been gross total resection, or GTR, which essentially means removing 100% of the T1-weighted contrast-enhancing tumor volume. But as we know, GBM is a disease of the whole brain. The tumor doesn't stop where the contrast ends.
Exactly, Dr. Aris. That's the crux of this meta-analysis. The authors are looking at supramarginal resection, or SMR. For those listening who are still in residency, SMR involves going beyond that contrast-enhancing border, often into the flare hyperintensity zone, to try and capture those infiltrative cells that we know lead to recurrence.
It's a bold approach because it challenges the oncofunctional balance. We want to take more out to help the patient live longer, but we can't risk their quality of life or neurological function. This paper attempts to settle whether that extra push actually translates into better outcomes. Elara, what was the primary objective of this systematic review?
The researchers wanted to compare GTR and SMR specifically in terms of survival outcomes, meaning overall survival, or OS, and progression-free survival, or PFS. But also, crucially, they looked at post-operative neurological complications and the Karnofsky Performance Status, or KPS, to see if we're paying too high a price for that extra resection.
Let's dive into the methodology. This wasn't just a small institutional series.
No, they performed a very rigorous systematic literature review. They pulled data from multiple databases, including PubMed, Embase, and the Cochrane Library. By the time they applied their inclusion and exclusion criteria, they were looking at a substantial pool of patients across several high-quality studies. They used hazard ratios, or HR, for survival, and odds ratios, or OR, for complications.
And for the residents listening, remember that a hazard ratio less than 1 in this context suggests a protective effect or a benefit for the experimental group, in this case, the SMR group. So, Elara, what did the survival data show?
The results were quite striking. For overall survival, the meta-analysis found that supramarginal resection was significantly superior to gross total resection. The pooled hazard ratio was notably below 1.0, indicating that patients who underwent SMR had a statistically significant reduction in the risk of death compared to those who only had GTR.
That's a powerful statement. We've always suspected it, but seeing it consolidated in a 2026 meta-analysis reinforces that the rim of the tumor is where the battle is won or lost. What about progression-free survival? Does SMR actually delay the tumor coming back?
Yes, it does. The study showed a clear benefit for PFS as well. The time to recurrence was significantly extended in the SMR cohorts. The paper emphasizes that because most GBM recurrences happen within a 2-centimeter margin of the original contrast-enhancing cavity, resecting that supramarginal zone effectively removes the very seedbed of recurrence.
Now, let's talk about the elephant in the room. We're neurosurgeons, our first rule is primum non nocere. If I'm resecting non-enhancing flare signal, I'm moving into brain tissue that might look normal but is actually infiltrated. Does this study show an increase in permanent neurological deficits?
This was actually one of the most interesting parts of the paper. When they analyzed the odds ratio for post-operative neurological complications, they found no statistically significant difference between SMR and GTR.
Really? No significant difference?
That's what the data suggests. While you might expect SMR to be riskier, the studies included in this meta-analysis often utilized advanced intraoperative technologies, things like neuronacadation, functional MRI mapping, and intraoperative neuromonitoring, or INOM. The authors argue that when SMR is performed in non-eloquent areas, or guided by robust mapping, it doesn't necessarily lead to more deficits than a standard GTR.
That's a critical caveat for our practicing surgeons. SMR isn't a license to resect blindly. It's a controlled extension of the resection, likely in the right-sided frontal or temporal lobes where the functional price is lower. Did the paper mention the Karnofsky Performance Status?
It did. They looked at the mean change in KPS scores postoperatively. Again, there was no significant decline in the SMR group compared to the GTR group. This suggests that the patients are not only living longer, but are maintaining a similar functional status.
Let's look at the why for a second. The paper discusses the biology behind these findings. We know that glioblastoma cells are highly migratory. By the time we see a contrast-enhancing mass on a T1 MRI, the cells have already moved into the surrounding edema.
Exactly. The paper refers to the non-contrast enhancing, or NCE, portion of the tumor. The meta-analysis confirms that GTR, while better than a subtotal resection, still leaves a high burden of microscopic disease. SMR addresses this by lowering the residual tumor burden to a level that perhaps makes the subsequent temozolomide and radiation more effective.
It's about cytoreduction. If the starting line for the adjuvant therapy is a smaller number of cells, the overall survival curve shifts. Now, were there any limitations mentioned in the study? Every meta-analysis has them.
Definitely. The authors pointed out that there is still a lack of large-scale prospective randomized controlled trials, or RCTs, specifically comparing SMR and GTR. A lot of the data comes from high-volume centers, where surgeons might be more comfortable pushing those boundaries. There's also the issue of selection bias. Surgeons might only attempt SMR in patients whose tumors are in safe locations, which could naturally lead to better outcomes.
That's a fair point. If the tumor is wrapped around the motor strip, no one is doing a supramarginal resection. So the SMR group might inherently consist of easier cases from a functional standpoint. Did the paper offer a standardized definition for SMR?
They noted that definitions vary across the literature. Some studies define it as resecting a specific margin, like 1 to 2 centimeters beyond the contrast, while others define it as the complete resection of the flare hyperintensity signal. The meta-analysis grouped these under the umbrella of SMR, but they suggest that future research needs a more unified surgical definition to make results more comparable.
That's an important takeaway for our residents. When you read SMR in a paper, look at the surgical technique section. Are they resecting the whole flare volume or just a margin?
Another point the paper dives deeper into is the use of 5-ALA, or fluorescence-guided surgery. While not every study in the meta-analysis used it, the authors noted that 5-ALA often reveals vague fluorescence beyond the solid tumor mass, which aligns perfectly with the goals of SMR.
It's all about visualizing the invisible. So if we're summarizing this for a board exam or a clinical round, what's the bottom line of this Brain and Behavior 2026 study?
The bottom line is that supramarginal resection significantly improves both overall survival and progression-free survival in glioblastoma patients when compared to gross total resection. Furthermore, when performed with appropriate surgical adjuncts, it does not significantly increase the rate of neurological deficits or decrease the patient's functional status, or KPS.
It's a shift in the paradigm. GTR is no longer the ceiling. It might be the floor. If you can safely take more, the evidence increasingly suggests you should.
It really highlights the importance of the oncofunctional balance. We aren't just debulking anymore. We are trying to change the natural history of the disease by being more aggressive in the initial stage.
Wonderful summary, Elara. To our listeners, this study is a great reminder to keep pushing the boundaries of what's possible in the OR, provided we keep the patient's function at the forefront of our minds.
Definitely. For those interested in the specific hazard ratios and the forest plots, we highly recommend checking out the full text in Brain and Behavior.
That's all for today's episode of the Neurosurgery Hub Podcast. I'm Dr. Aris.
And I'm Dr. Elara.
We'll see you in the next one. Keep learning and keep operating.